Hi, this is Dr. Julia Jenkins, and I'm giving a lecture on the 2025 AHA-ACC Hypertension Guidelines, really just some of the highlights and key takeaways when we're taking care of our patients with hypertension. I did give this talk recently at the end of March 2026 for Baycare Medical Group's primary care huddle. So why is this important? We know that hypertension is among one of the most important diagnoses that contributes to cardiovascular disease and mortality. These five particular disease states were found to be the most impactful when we're talking about cardiovascular morbidity and mortality. Hypertension does seem to have the most significant, is the most significant risk factor, but obviously dyslipidemia and obesity, smoking, and diabetes are also very important risk factors. So these five modifiable risk factors together account for over half of cardiovascular disease events and 20% of deaths globally. So since it is such an important disease state, how are we currently doing managing hypertension? And unfortunately, there's a lot of area of opportunity here. So nearly half of the adults in the United States have hypertension, but unfortunately, about 41% of women and 51% of men that have hypertension are not yet diagnosed. So we have opportunities for screening. And then when they are diagnosed, unfortunately, fewer than 1 in 4 women and 1 in 5 men are actually controlled and at goal, according to evidence. So this is definitely an area where primary care can make a big impact. So we're going to talk about the diagnosis based on some of the guidance from the new guidelines. And so in our offices, we generally will use some type of blood pressure cuff, and a lot of us use the automated cuffs. What that's going to miss is what we call masked hypertension. So approximately 1 in 8 adults that we're seeing in our offices will have high blood pressure readings, but they won't show that in the office. And so it really, really is important that we're trying to teach our patients how to take good blood pressure readings at home and that we do community screenings. And so the gold standard is to do an ambulatory blood pressure cuff, but that can be difficult to access. So we can teach our patients how to do good readings using their home cuff. And there's a website called validatebp.org that you can give to your patients that talks about which cuffs are validated and are recommended and how to take a good blood pressure. So just a few tips that we want to teach our patients and our staff is that we really want to make sure our arm is supported and relaxed, that we don't have to pee because that makes our blood pressure artificially elevated. We're not crossing our legs. We have our back supported. We're not taking our blood pressure right after caffeine and being mindful about, other medications that we've taken. So if you want a good resource for your patients and also for providers and for staff, the American College of Cardiology, they have this website called CardioSmart. So if you go to cardiosmart.org and then you go to blood pressure, it gives you a lot of great handouts on what the new cutoffs are for our blood pressure, our systolic specifically, what are some good lifestyle measures to think about, even recipes and diet advice. So really fantastic resource. And they have apps as well. This is another kind of key point that we need to be aware of when we're looking at blood pressure is that it's very normal for most people to have higher blood pressures during the day, and then our blood pressure tends to dip in the evening. So that would be kind of the blue line on this graph where it's high during the day and lower at night. But there's more and more people that are becoming what we call reverse dippers, where their blood pressure will be a certain level during the day, but it actually goes up at night. That is more prevalent in patients with sleep apnea and in patients as we get older. It's definitely carries a higher cardiovascular risk if somebody's a reverse dipper. And so it's really important that when we have patients monitoring their blood pressure, we're not just looking at blood pressure in the morning, that we're having them check it in the evening. So it's really, really important that if we suspect there are reverse dipper that we're looking at blood pressure at different times during the day. It's also really important that we think about the half-life of our antihypertensive medications because of this, and so we're going to talk more about that at a later slide. So in the new 2025 multi-society guidelines for hypertension, a lot of organizations and different types of providers came together, and it more matches global guidelines. And so stage 1 and stage 2 hypertension has remained the same. We start to call it hypertension when the systolic is above 130. So that is the number to remember, is 130. It becomes stage 2 when it's above 140. But we are getting rid of the terminology hypertensive urgency. The reason is a lot of our patients that have blood pressure systolic readings above 180, they don't necessarily need to be sent to the emergency department. So if your patient has a systolic of 180, but they're not endorsing things like chest pain or shortness of breath or vision changes, numbness, weakness, that is something that could be managed on the outpatient setting. But if they have any signs of end organ damage or any of these symptoms, that you would want to send them to the hospital. When we first diagnose a patient with hypertension, we want to look at their other cardiovascular risk factors. So this is giving some of some guidance on what we should look at, including cholesterol and blood sugar and kidney function and ruling out thyroid disease. But the really big takeaway from the new guidelines is that every single patient who has a new diagnosis of hypertension or an existing diagnosis, we need to be checking their urine albumin to creatinine ratio every single year. And this is not just for diabetics. The reason is hypertension is a significant risk factor for developing chronic kidney disease, and the earlier we find that, the better. So really, really important that we start looking at urine albumin to creatinine ratio in all of our hypertension patients. And that may also guide your doses and your medication choices. If you notice that they have microalbuminuria, the renin, aldosterone, angiotensin system becomes really important, and it just changes our management. So the cutoff that we're looking for when we measure this urine albumin to creatinine ratio is greater than 30 micrograms per milligram. And again, it's really showing early signs of microvascular damage related to hypertension and other cardiovascular disease states. We may actually decide that we're going to increase our ACE inhibitor or our ARB dose when we see this and monitor it to see that it's improving. We're also, when we see this ratio elevated, we're going to be more aggressive with our systolic blood pressure, because this is a significant risk factor for cardiovascular disease. According to our kidney guidelines, we're going to want the systolic less than 120, not less than 130. We're going to limit dietary sodium and encourage weight loss. And then we're going to think of some of these agents like SGLT2 inhibitors, which are renal protective, and GLP-1s, which also are renal protective in certain patients. So now we're going to talk about our systolic blood pressure goals. It really is important that we're starting to understand and realize that the systolic blood pressure goal should be less than 130 for all of our patients, not just for high-risk patients, not just for diabetics, not just for patients with kidney disease. There is very strong evidence to support this, and all of us really should be trying very hard to get our systolic blood pressure less than 130 for all patients, and with the caveat that there may be some patients that are frail and older that might not tolerate aggressive blood pressure lowering, so taking that into context. But really, that should be the exception and not the general rule. The reason that people kind of get a little confused about what this guidelines are recommending is because we've really changed our guidance for blood pressure management over the years. You know, we started with JNC7 and it was systolic of less than 140 for most people, but less than 130 for diabetes or kidney disease. Then we had JNC8, where we actually relaxed our systolic blood pressure goals for older adults. And then the ACC AHA in 2017, they kind of went back on that as the data started to come out for older adults that we really needed to keep that blood pressure goal of less than 130 for most people. The globally and the European Society for Cardiology agreed, and they gave us guidance that really our systolic should be definitely less than 120. Definitely less than 130, but maybe even less than 120 for high-risk folks. And when we look at the evidence that's come out over the past 10 years or more, lowering your systolic blood pressure goal from 140 to 130, it significantly cuts your stroke risk, your heart attack risk, your incidence of heart failure, and actually the benefits of aggressive blood pressure lowering is better if you're older. So there's less development of chronic kidney disease and ASCVD risk, and we're going to talk about other risks. But this slide is just here for reference to show you some of the research that's led us to having more aggressive blood pressure goals. So really a lot of good data to support lowering your blood pressure goal for most adults to less than 130. Some trials even with blood pressure goals less than 120, but we kind of reserve that for our patients with diabetes or chronic kidney disease or elevated cardiovascular risk. So significant risk reductions when we have more intensive blood pressure goals. So I really just want to drive home the fact that the evidence does support more aggressive blood pressure lowering in our older adults. So in the SPRINT trial, they looked at lowering a systolic to less than 120 versus a goal of less than 140. And these were adults greater than 75 years old. They had less cardiovascular events by 34%, less all-cause mortality by 33%. And they also looked for side effects and risk with the more aggressive goals. There was no significant increase in falls or orthostatic hypotension. There was some very minor AKI electrolyte issues that were easily fixed with medication adjustment. In the STEP trial, which again was older adults, they were aiming for a systolic blood pressure goal of 110 to 130, a goal of 110 compared to a less aggressive goal of 130, and it lowered cardiovascular events by 26%. And I apologize, I'm saying this a little wrong, but the more intensive goal was more beneficial than the less intensive goal. And then in the SPRINT MIND trial, this was really interesting. They found that a more strict systolic blood pressure of less than 120 was linked to less risk of cognitive impairment in adults greater than 50 compared to a less strict goal of 140. So nothing scares my patients more than dementia and Alzheimer's disease and cognitive impairment. So I think this is a really important part of our discussions with patients. So I'm going to also talk about treatment, and the new guidelines do encourage a trial of lifestyle modification, but only for patients that are low risk as used, as defined by the new PREVENT score, which I'm going to talk about on the next slide. But if they do have stage 2 hypertension, or if they have other risk factors, then we want to jump right into medication and we don't want to wait. So if the systolic on average is greater than 140s, if their PREVENT score is greater than 7.5, if they have diabetes or chronic kidney disease, or if they've already had an event or they have clinical ASCVD, we're going to want to jump right to medication with our systolic blood pressure goal of less than 130, less than 120 for higher risk patients. So what is this PREVENT score? This is the American College of Cardiology, the American Heart Association, trying to do a better job with the risk assessment beyond the pooled cohort equation that we've been using for years. It looks at younger ages, so we're trying to capture people earlier, starting at 30. It removes race from the equation, which tend to not necessarily be applicable to our individual patient and not necessarily accurate. It also includes renal function and this urine albumin to creatinine ratio. It includes A1C, and it also looks at the social determinants by including a zip code. It'll give you a 10 and 30-year risk, and you have to remember that this does really help us understand risk, but it doesn't necessarily help us if they have genetic hyperlipidemia syndromes like homozygous or heterozygous familial hyperlipidemia. And it also may not help us if they have elevated, really high levels of lipoprotein A and other genetic lipid disorders. So for lifestyle measures, when we're talking to our patients, we can direct them to heart.org and Life's Essential 8. And obviously, things like exercise and sleep and smoking and alcohol are going to impact our blood pressure. So you have to have a conversation about those things. And then when we're starting medication, it's really important that we start one of these 3 types of blood pressure medication because these are our first line therapies. So we're going to want to consider ACE inhibitors or ARBs, and that's going to help with that RAS activation. We're going to think about calcium channel blockers like amlodipine or our non-dihydropyridines. And just to kind of touch on that a little bit, we tend to lean into amlodipine and use that a lot. We may not want to use that if they're having a lot of lower extremity edema from the amlodipine. Non-dihydropyridines like diltiazem or verapamil, those could be useful if you also have some type of arrhythmia, like atrial fibrillation or tachycardia, or even for angina. But you would not want to use a non-dihydropyridine calcium channel blocker if they have heart failure with reduced ejection fraction because it does reduce heart contractility. Thiazide diuretics are also first line, and that can be hydrochlorothiazide or something like chlorthalidone. They've done research to show that although chlorthalidone is the longer acting of the thiazide diuretics, that they are seeing probably the same outcomes, whether you use the chlorthalidone or the hydrochlorothiazide. So they seem to be pretty equivalent. And you have to be really careful with chlorthalidone because it tends to be a little more potent. And so you have to watch the potassium. Both thiazide diuretics will lower potassium, so you have to watch the levels really carefully. I will point out that beta blockers are not first-line therapy for treating hypertension. If you're using it for some other reason, like they do have heart failure with reduced ejection fraction, or they have migraines, or they're taking it for some other reason, then you may want to continue it, but it is not first line for hypertension. I wanted to spend a little extra time on ACEs and ARBs because there's a couple of things that really need to be highlighted, especially with the new recommendations. So ACEs and ARBs, just being aware that especially ACE inhibitors, we have to look for cough and angioedema. ARBs are a lot more accessible and can be considered first line because they have less of a risk for cough and definitely have some other things we're going to consider, but very inexpensive and accessible. So in the new guidelines, we want to recommend an ACE or an ARB if there is any signs of early kidney disease or microalbuminuria. So this really, in our 3 first-line agents, should be considered before the other 2 if they have an elevated urine albumin creatinine ratio or any signs of kidney disease. And unlike our thiazides that lower potassium, ACE inhibitors and ARBs can increase potassium, so you're going to want to monitor the potassium when you're starting or adjusting these agents. It's not unusual to see a little bit of a decline in our renal function markers when we're starting an ACE or an ARB because of the way these medications work. So if you see a little bit of an increase in your creatinine or a little decrease in your GFR, that's okay and kind of to be expected. But if you're seeing a greater than 30% change in your renal function, then you're going to think about renal artery stenosis, and you're probably going to need a nephrologist to get involved. This is a really important slide because a lot of us who are in primary care use losartan when we do choose an ARB. And the reason for that, it was the first generic ARB. Unfortunately, losartan has a very short half-life. So I want you to remember we talked about reverse dippers and how prevalent that's becoming and how often people will have higher blood pressures at night. So if your patient is taking losartan first thing in the morning, it's likely not in their system anymore later in the day and in the evening. So on the package insert for losartan, it is recommended to be a BID medication. So if you're going to use losartan, I would consider using it BID or just use a different ARB because the other ARBs are becoming more accessible and less expensive and covered well by insurance. So consider using another agent. Losartan is also not the most potent of the ARBs, so things like candesartan and telmisartan and olmesartan, you're going to get more of a blood pressure reduction than you are with losartan. And the other really interesting thing, which I've been changing a lot of my ARBs because of this research, is there are specific ARBs that cross the blood-brain barrier and that will lower the risk of cognitive decline and lower the risk of dementia. So they've, in research, been able to show a measurable decrease in neuroinflammation and in the buildup of beta amyloid and tau proteins and less oxidative stress by using the particular ARBs that do cross the blood-brain barrier. So I made up a mnemonic to remember the 3 ARBs that are a little better at crossing the blood-brain barrier and have shown to decrease cognitive decline. And that would be CTV, like seeing the television. So CTV stands for candesartan, telmisartan, and valsartan. Also, losartan and irbesartan, they do cross the blood-brain barrier a little, but not as well as candesartan and telmisartan and valsartan. So really, if you're going to avoid an ARB that may not be as helpful as the others, it would be olmesartan. But I really would think of CTV when you're trying to pick an ARB and your patient has any concern for cognitive decline or family history of dementia. The reason that these particular ARBs do better than ACE inhibitors and other ARBs is that they target certain receptors. And this selective targeting helps those ARBs in promoting neurogenesis and improved memory and enhanced blood flow, whereas the ACE inhibitors and the ones that are non-selective is not blocking inflammation and oxidative stress and buildup of amyloid and tau. So that's just the mechanism if you're wondering. Lastly, we're going to talk about resistant hypertension, and that's when your patient is on 3 first-line agents and you're sure that they're taking their medication and they're definitely not a pseudo resistance where maybe they're not measuring their blood pressure properly, or maybe they're not taking their medication every day. So they're on 3 agents, but they're still very difficult to control. The first thing you want to think about when you have a patient with resistant hypertension is if they're going to need a little bit of a secondary workup, specifically thinking about sleep apnea, which is very prevalent among patients with resistant hypertension. And then also specifically thinking about primary hyperaldosteronism. So in the new guidelines, there's a recommendation that we should be screening for hyperaldosteronism in all of our patients with sleep apnea and with resistant hypertension. You can also think about screening for this in patients where they have an adrenal mass or you're seeing low potassium that's not explained by other reasons. Also, if they have hypertension at young ages, or if they've had a stroke at a young age, you'd want to screen for this. A lot of the primary hyperaldosteronism is found in patients with resistant hypertension, up to 20% of patients with resistant hypertension, but even 8% of patients with hypertension will have high aldosterone levels. The most common cause is bilateral adrenal hyperplasia coming from the adrenal glands, where the remaining third of those patients are unilateral adrenal mass or adrenal tumor called Conn syndrome. And they don't always have low potassium. So if you do not see low potassium, they still could have elevated levels of aldosterone. So you want to be suspicious, again, if they have sleep apnea or if they have resistant hypertension. The cutoff is 30 is what's widely accepted, although some organizations and specialists have a lower cutoff than that. So the aldosterone-renin ratio greater than 30 is going to help you make the diagnosis of primary hyperaldosteronism. The renin level is going to be your tiebreaker, because if the renin is low, that means that the high aldosterone levels are coming inappropriately from the adrenal glands and it's suppressing renin activity. But if the renin level is high, then that's tells you that that is a secondary cause for the hyperaldosteronism. So for example, in patients with poor kidney perfusion or renal artery stenosis or heart failure, their kidney is appropriately, they're increasing renin and then increasing aldosterone, which is the body's way to respond to low perfusion in the kidney. The only medication you really need to make sure your patient is not taking when you check renin aldosterone tests are things like spironolactone, our mineralocorticoid receptor antagonist medications. The rest of the medications, they can continue, and they probably should continue, because these patients tend to need several medications to control their blood pressure. It can be dangerous to take them off these medications. And what they've shown in research is that the renin aldosterone levels are not significantly impacted by ACEs and ARBs and other types of antihypertensive medications. So go ahead and continue them, but they should not be on spironolactone. So we're going to end with a case, and this is just to kind of bring it all home. So we've got a 66-year-old patient with hypertension, obesity, and sleep apnea. They're already on 3 first-line agents. They're on losartan, 100 milligrams once a day, hydrochlorothiazide once a day, and amlodipine, a calcium channel blocker, once a day. You check their blood pressure at their visit, and it's 142/85. The patient's like, it's better at home. That's probably some white coat hypertension. I was stressed driving here. So what do we do with this patient? What are some opportunities? One we need to think about is this truly white coat hypertension, or could this patient be a reverse dipper, because they do have sleep apnea, so they may actually have higher blood pressures at night. We definitely want to think about the lifestyle factors and talk to them about exercise, alcohol, their sleep habits, and blood sugar and obesity and all those things. Life's Essential 8. We're going to want to consider adjusting their medications. The losartan, maybe that should be BID. Maybe we should switch it to a longer acting ARB like telmisartan. The hydrochlorothiazide is a short acting thiazide, but probably equivalent to the chlorthalidone. So we may or may not want to adjust that. We definitely want to think about checking a urine albumin to creatinine ratio in all of our patients with hypertension. So if it is elevated, then we want to really maximize what we're doing with our ACEs and our ARBs. So that would be another reason to want to adjust the losartan. Because this patient is on 3 first-line agents and still looks like they have elevated blood pressures, we should consider an aldosterone-renin ratio. within the Baycare system, that is a send-out lab, and this is what the order would look like, is aldosterone-renin ratio. And if the patient is concerned, has any family history of dementia, or they're personally concerned about cognitive decline, then we may want to consider changing that losartan to one of the CTV ARBs like candesartan or telmisartan or valsartan. Finally, and I hope this was kind of the main message for this lecture, is that our systolic blood pressure goal should be less than 130 for all patients, even less than 120 if they have more risk factors. So we're going to try to make sure we're getting accurate blood pressure readings, help them get accurate readings at home, get evening readings, and then really make sure the systolic blood pressure is less than 130. So these were the practice recommendations that we went over during this lecture. Remember, there's a very good website called cardiosmart.org that we can guide providers to and our patients to. We're going to be on the lookout for mast hypertension and reverse dippers. We're going to check a urine albumin creatinine ratio for all patients with hypertension. The DASH diet is a very powerful tool for lowering blood pressure, and so is Life's Essential 8. First-line treatments are ACEs, ARBs, calcium channel blockers, or thiazides. It is not beta blockers and other types of medication. Hesitate before prescribing losartan. It has a short half-life. We have very inexpensive other ARBs that probably work better, especially if we're worried about dementia risk. Think about hyperaldosteronism, especially in our patients with sleep apnea, which sleep apnea is a contributor to hypertension and AFib anyway. And then we want to think about an aldosterone-renin ratio if they have resistant hypertension or if they have sleep apnea. And again, systolic blood pressure goal, less than 130 for all ages, all comorbidities, unless there's contraindications. If you have any questions, this is my email address, and this is just a few pictures from our teaching kitchen, really encouraging lifestyle as medicine. And so thank you so much. I hope you found this to be helpful.